Hello, guys. I hope you're doing good. We will be starting our session right now. So, if your friends haven't joined, then ask them to join. The official starting time will be 8:05. A lot of students were complaining about the time management issues, so we decided to, start conducting the class at 8:05. Even if you decide to join a bit later, again, that's your loss. The sessions are recorded, so you can always go on YouTube and continue watching the sessions over there. All right, so we will be starting our session. Okay. All right. Okay. So the first question we have of today is that a beta HCG level is greater than 100,000 and an ultrasound shows no fetus and a uterine cavity filled with multiple small cysts. What does this mean? So a beta HCG greater than 100,000 and multiple small cysts. What does this mean?
Polycystic ovarian disease.
PCOS? You sure? Do they have beta HCG of 600,000? What is it?
No.
Yeah. Multiple small cysts. Yeah. So they're talking about of any sort of mole, maybe. It can be a complete mole, it can be a complete mole. Okay. And they're saying the patient undergoes DNC and a friable mass of tissue consisting of many thin wall cyst is evacuated from the urine. Damage in the tissue would most likely show to the following karyotypes. Yeah, so they're talking about any sort, like I said, that they were talking about a mole, because usually in moles, you have a beta HCG greater than 100,000 and you have multiple small cysts. What type of mole will it be?
It will be complete mole.
All right, okay. And what do you see? What's the chromosomal number?
I think it's 46 XX.
All right, anybody else?
Yes, it's the complete mole, and the most common form is the 46XX. Because there is no fetal tissue. If there is fetal tissue presence, it will be partial mole, and the partial mole will be 69XXY, or it could be XXX or XYY.
Very good. So they were referring to any a high dilated form mole. Yeah, do you know what a high dilated form mole is? Can anybody tell me? Guys, it's your USMLE step 1 that you're preparing for. I'm not preparing for my USMLE step 1. I'm already matched at a residency program. So, if you're not going to input into this, then I won't bother asking you these questions.
Yes, the high dentiform mole is basically the abnormal pregnancy in which there is cystic swelling of all the chorionic villi takes place, and the proliferation of chorionic epithelium takes place. That's basically the trophoblastic membrane. And patient presents with heavy bleeding, and it's also associated with high levels of beta HCG. So always monitor. We should monitor the beta HCG levels if we find pregnancy. Yes, and it is of two types: complete mole and partial mole, in which we find the fetal tissue, that will be the partial mole; in which we don't find any fetal tissue, that will be the complete mole. And we find the cluster of grapes appearance on the or the honeycombed appearance.
No,
Yes,
on
and
ultrasound we see the snowstorm appearance on ultrasound. And on DNC, when we do the DNC, we see the cluster of grapes, typical cluster of grapes appearance.
All right. Okay.
Yeah.
Anybody else? Does anybody else want to have their input? No? Okay. How do we treat moles?
For the management, we have to do the DNC first. That's the suction curettage, and the quantitative measurement, the estimation of the beta HCG levels. The contraception should be advised to the patient for the 6 months of the period. So these are the management options.
And also
All right.
follow up for the
Also,
metastasis.
methotrexate.
Very good. Yeah.
Mhm.
All right. So we know that moles are divided into complete mole, partial mole, invasive mole. They can even turn into, a thing called choriocarcinoma. So complete mole is basically an empty egg that's fertilized by a single sperm. And we know that the sperm then kind of duplicates its DNA. And that is why we have the formation of 46 double XX. Again, 46 by it's not compatible with life, and that is why you don't see it in the answer options over here as well. It results in a snowstorm appearance on the ultrasound. On the ultrasound, you will see the snowstorm pattern. I want you guys to see what this is. All right, okay. So do you see this? All of this. All right, so this is echogenic uterine mass with multiple cystic areas. Again, you will see a snowstorm pattern. Let me go again. Yeah, so this is referred to as a snowstorm pattern. And again, it can refer to as bunches of grapes as well. On gross pathology, there are no fetal parts present. Again, both complete and partial moles, they have high risk of progression to invasive mole, or they can develop into a choriocarcinoma. Again, USMLE wants surgical evacuation via DNC or curettage as the treatment. All right, and partial mole. So we know the partial mole is the incomplete mole. And why is it an incomplete mole? Because the normal egg gets fertilized by the two sperms, and that is why you have a karyotype of 69X triple X, 69 double XY. It can be anything. Fetal parts are also present, and it can also be an invasive mole. What do you mean by invasive mole?
Which needs some invasive procedure to remove.
No. So invasive mole is a form of gestational trophoblastic disease that where the molar tissue is penetrating into the myometrium, and that is why it's called as the invasive mole. It carries the potential for metastasis and progression to choriocarcinoma. Again, the gross pathology will be showing you the presence of chorionic villi in contrast to choriocarcinoma. Now, what do you mean by choriocarcinoma? What's that? No? All right. Okay.
This is
Okay.
the
Yeah, so it's a cancer of the inside trophoblastic placental tissue. Again, it usually develops from a hydatiform mole, but not always. Again, they have also elevated levels of high beta HCG, super high levels. That is why if you see that a beta HCG level is greater than 100,000, then that's really worrisome, because it can also be suggestive of choriocarcinoma. Again, they love to metastasize to the lungs and the brain. Again, USMLE will be giving you a woman who has ultra elevated beta HCG with pulmonary nodules or stroke-like presentation. If they're going to tell you that, and that probably means that they're referring to choriocarcinoma. Again, so whenever you see that a uterus that's kind of big for the gestational ages, most of the times they're referring to a mole. All right. Okay. Then we go to the next question. All right, pelvic ultrasound reveals a normal size uterus and left ovary. There is right axial mass measuring 6 centimeters with absent blood flow to the right ovary. What does this mean? Absent blood flow.
Torsion.
Torsion. Very good. And that is how you kind of differentiate ovarian torsion with other, causes of pelvic pain. Urine beta HCG is negative. The patient's condition most likely arises from obstructed blood flow to which of the following reasons. It's very easy.
Infundibular pelvic.
Infundibular pelvic.
Exactly. Again, so we know that this case was ovarian torsion. Whenever a patient comes to the ED with severe pelvic pain, and so and if it's right-sided, it can be, appendicitis, it can be ovarian torsion, and the only way to distinguish is by, doing an ultrasound. If it shows absent blood flow, then that means they're referring to ovarian torsion. Again, the patient will also have nausea, vomiting. Again, that's, kind of suggestive of appendicitis. Again, we know that the ligament that they twist onto is the infundibulopelvic ligament. Again, very high yield point. All right. We come to the next question. So we have a 15-year-old girl. She comes to the office due to pelvic and crampy lower abdominal pain. It seems to reoccur at the beginning of each month and resolves after a day or two. The pain began approximately 6 months ago. The patient's never had a menstrual period. She has never had sexual intercourse. Everything is normal. Breast and pubic hair development are at 10 or stage 5. DRE reveals a palpable mass anterior to the rectum. Pregnancy test is negative. Which of the following is most likely? The diagnosis is very easy. What's happening?
Imperforate hymen.
Exactly.
Yeah.
Imperforate hymen. Why? Because first of all, there is a mass. Second thing, everything else is normal. All right. So two things, everything else is normal. Number two, again, there's a certain mass that they're referring to. What do you mean by Kalman syndrome? What's Kalman? What do you mean?
Kalman
Yeah.
In Kalman syndrome, there is decreased synthesis of gonadotropic releasing hormone, like decreased GnRH, like FSH and LH and testosterone, and also more common in males. With the more important thing is anosmia in these patients, loss
Very
of sense.
good. Very good.
Yeah.
Anosmia,
Yeah.
reproductive problems. Whenever you have anosmia and reproductive problems, Kalman. All right. What do you mean by Asherman syndrome?
There are fibrous glands in the uterus.
Yes, the fibrosis of the uterine cavity takes place in Asherman's
Yeah.
because
Yeah.
Even any sort of DNC, any
Because
sort of intrauterine procedure, sometimes the endometrium gets kind of injured, and that is why we can also develop Asherman syndrome. All right. And what do you mean by androgen insensitivity? What's that?
This is a defect in androgen receptor, resulting in a female appearing genetic males like the 46XY.
Yeah, they have male karyotyping, but the female external genital appearance.
Yeah.
SRY.
And the poor secondary sexual characteristics like the scanty axillary hair or the poor breast development. Yeah.
That's malaria.
Very good. The other thing I want to mention about imperforate hymen is that you also see a bluish white membrane. All right. On examination, they've not mentioned it over here, but sometimes in USMLE step 1, they mention that there is this bluish white membrane seen on the examination. I don't know if it's mentioned over here. Let me see if they've mentioned it here. No.
I have a question, Dr. Maheen, that where is bluish white membrane?
Yeah, so the reason that it's bluish is because on the outside it looks bluish, but it is bluish because of the retained blood, and because of the light that's putting onto it. As we're viewing it from the outside, it appears a little bit bluish. So that's imperforate hymen. Usually they're referring to that. All right. Let me see if they've mentioned it over here. No, they haven't. But they sometimes see that. So whenever you see bluish white membrane on USMLE step 1, most of the times they're referring to imperforate hymen. All right. See, there's this blood over there. No, they haven't mentioned it over here. Again, you incise the membrane, and then the blood comes out. It's solved. All right. Okay, then we go to the next question. Okay. The patient plays violin for her high school orchestra. Her BMI is normal. All right, examination shows fully developed secondary sexual characteristics. Pelvic ultrasound, shortened vaginal canal. All right, with a rudimentary uterus. What does this mean?
Turner syndrome.
Rudimentary means not properly developed.
But how can it be? So it's Kalman?
No, it's Mullerian
No,
agenesis,
Turner.
right?
Mullerian agenesis.
Mullerian agenesis. Yeah.
Posterior Turner.
Very good. All right. Okay. Yeah. So again, how will you differentiate Mullerian agenesis with androgen insensitivity? How?
Mullerian agenesis, they have normal hormone levels, but in androgen insensitivity, because there's a receptor defect, they have high estrogen and testosterone level. And also,
I'll give you just one thing. I'll just give you one thing that you guys can remember, even if you don't remember all of it. Ovaries. All right. Check, look for ovaries. So in Mullerian agenesis, you will have ovaries. All right. In androgen insensitivity, there's nothing. All right. So just one thing I would want you to remember, even I don't remember all of this. So it's okay. But just see that if, there are ovaries that are present, then that means you're referring to Mullerian agenesis. But if the entire thing is absent, then that means you're referring to androgen insensitivity. All right. Again, yes, you were right about the hormonal level as well. Mullerian agenesis, you have normal estrogen and testosterone, whereas in AIS, you have increased testosterone and estrogen. Again, Mullerian agenesis is also known as Mayer-Rudinansky-Koster-Hauser syndrome. Again, a very tongue twister of a name. Okay. All right. What do you mean by 21 hydroxylase deficiency? What's this? Come on, guys. What does that mean?
This is the congenital adrenal hyperplasia.
And
Yeah.
that is the most common type of
Most
CA.
common cause, yeah. And patient usually presents with hirsutism, oligomenorrhea, and ambiguous genitalia.
Very good.
And usually the neonate presents with the hyponatremia, life-threatening hyponatremia.
All right. Okay. Very good. How are you gonna assess that if it's Mullerian agenesis or androgen insensitivity? Like, what test will you do first?
We should look first for the presence of the secondary sexual characteristics, meaning if ovaries are present, but the ovaries are absent in Mullerian agenesis. Yeah.
All right. Okay. So whenever they say that the vagina ends in like a blind pouch, or whenever they say that there's this, so what does that mean? What if they say that the vagina ends in a blind pouch?
That will be Turner syndrome.
You sure?
Dysgenesis.
Yeah. In Turner syndrome, the vagina has a blind pouch, and in Mullerian agenesis, the vagina is a short vagina. Yeah.
All right. Okay. What if the pubic and axillary hair was absent too, and it was a shortened vagina? Then what?
Then Mullerian agenesis.
No, androgen insensitivity. So whenever they say that the vagina ends in a blind pouch, and they're referring that the pubic axillary hair is also absent, and there's this 15-year-old girl who was brought to the physician and by her mother for not having a menstrual period, and the vagina is ending in a blind pouch, and there's pubic axillary hair that's absent, and that means they're referring to androgen insensitivity. All right. Again, then you first do an ultrasound before doing a karyotype. And yeah, okay. In Mullerian agenesis, they would also say that the vagina ends in the blind pouch, and the pubic axillary hair may be scanty or absent. But what will be the key away? What will be the giveaway?
Ovaries.
Very good, ovaries. All right, then we go to the next question. Okay, the patient is at the 5th percentile for height and 20th percentile for weight. Examination shows a high arched palate. All right, high arched, widely spaced nipples. Again, what are they referring to?
Turner's.
Turner syndrome.
Turner syndrome.
So
Okay.
it will be
And
C.
we finally see
Atrophic ovaries.
atrophic or
Atrophic
dystrophic
ovaries.
Yeah. So the picture is really important for you to memorize. Short stature, low hairline, web neck, broad chest with widely spaced nipples. Cubitus valgus, they don't ask, but they do ask about coarctation of aortic dissection, bicuspid aortic valve, horseshoe kidney, streak ovaries. Again, what's the treatment of Turner syndrome? What do you give in Turner syndrome? You give what?
Gonadotropes.
Yeah. What are they called as?
Um,
So you give GnRH hormones. Most of the times you give GnRH hormones in Turner syndrome. All right, okay. Then we go to the next question. On speculum examination, the anterior vaginal wall bulges with the valsalva maneuver. On bimanual examination, the uterus is small and mobile. Which of the following is the cause? So there's a 54-year-old postmenopausal woman. Okay, increasing vaginal pressure, BMI is A, B. What's happening?
Prolapse.
Prolapse. You try and prolapse. Oh,
Good,
vaginal
very
prolapse.
good.
Sorry.
Yeah, prolapse.
Yeah, it's
Prolapse.
anterior prolapse. All right. Then what do you see? What's the underlying cause?
Pudendal nerve
But
injury.
then nerve
Gender
damage.
nerve injury.
Oh, very good. All right. Okay. Yeah. So we know that the pudendal nerve, it kind of supplies a lot of things. And even if you have a vaginal delivery, there's a high risk that you injure the pudendal nerve. Again, so whenever they say that the patient comes to you with, any sort of pressure that's there, that means they're mostly likely referring to, any prolapse. It may be anterior or it may be posterior. Now, depending upon what's, prolapsed, what's herniated. If it's bladder, then most likely they're referring to anterior, and if it's rectum, then most likely they're referring to the posterior. All right. Yeah. So again, it's referred to as cystocele and rectocele. Alternatively, again, they will say that there's a vaginal bulge, or there's this feeling of sensation that's a little bit dragging them down. Those are the few words that they use to describe prolapse on USMLE step 1. All right, what is the treatment for prolapse? How do you treat it?
Surgically.
Surgically.
Right.
Surgically, very good. Yeah, so you do surgery. You put sometimes a pessary, or sometimes a sling, or sometimes you do surgery to remove it. All right, okay. Then we come to the next question. So what's happening? Short stature, web neck. All right, what are they talking about?
Turner syndrome.
Nerve
Turner
syndrome.
syndrome.
Okay, so karyotype analysis is performed and blah, blah, blah. Cells have 45X genotype, and the remaining has 60% contain a 46XX genotype. Which of the following is most likely of the condition? We know Turner syndrome is X0. All right, so how does it?
It's either C or D, mosaicism. I don't know which one. Maybe
Mosaic, yeah.
yeah, germline,
Somatic.
somatic. I think
Somatic.
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 Yeah, so it is somatic mosaicism.
Somatic mosaic syndrome.
Again, you don't have to memorize why it's happening, but just remember, that there's this thing called mosaicism, and somatic mosaicism occurs in Turner syndrome. All right. Then we go to the next question. Okay, high arched palate, low set ears. What does this mean?
Turner syndrome.
Turner
Again,
syndrome.
very good. Which of the following is a condition? What's happening?
Loss of
mitotic dysfunction of chromosome. Yeah.
Chromosome deficiency.
paternal copy of X chromosome loss. B.
The loss of
B.
exo.
B. Loss
Yeah,
of
again.
pattern copy.
So, yeah, one more thing I would want you to know regarding Turner syndrome is that there is a single cystic hygroma that develops. It's like a posterior neck mass, and it can present, within the Turner syndrome as well. They also can have congenital lymphedema. These are the two things that I would want you to add on to this picture. They are very high yield for you to remember as well. Okay. And we come on to the next question. Okay. What is this picture of?
This is a cross section of the lower genital area,
Genital
Very
area.
And
All
the
right.
image of CT scan of pelvis.
and the D is the inner canal. So the C should be the prostate.
All right. So what is happening? That there's this man who comes to the office due to poor urine flow for several months. All right. And the patient says it takes about 10 seconds to initiate a urinary stream. He also needs a strain when urinating, or the stream just stops before his bladder is empty. He has tried everything. What type of incontinence is this?
Stress.
It's stress? What? Stress? I'm getting a heart attack.
Overflow.
Oh, overflow. Sorry. Overflow incontinence maybe.
Yeah, very good. You almost gave me a heart attack. I was about to die. All right. Okay. Yeah, so what type of muscles get involved in that?
The trusser.
Where do you see that?
Poor urinary
Reflex
flow, so
maximum.
it means that it's because of
Reflex
BPH.
maximum.
It,
Yeah.
it's showing up the poor stream. So poor streaming of the flow, it means it's because of BPH, and the old age man also indicates that it's the BPH. This is the prostate C. That's because of they are asking for that drug.
All right. So
She,
you think
she
it's
asked a
C?
question.
Could you please show up the question? Yeah, they are asking for the drug finasteride. He
Yeah, so I told you that what type of, incontinence that they're asking, and they were talking about overflow incontinence. Again, overflow incontinence usually occurs in patients who have outflow tract obstruction. And where do you see them in BPH patients? Because the prostate, it kind of, presses on the urethra. And because of that, the urine does not pass through the bladder. And that is why, there's this thing called overflow incontinence. Again, it's an indication of BPH, and that is why you check for the post-void residual volume as well to kind of diagnose it. You give a lot of medication, 5-alpha reductase inhibitors, finasteride. You can also give alpha-adrenergic blockers, for example, camosulin. They also have control over hypertension as well, and they can also relax the smooth muscles in the bladder and neck as well. Again, it has both of the purposes. So they were talking about what's involved. So if you kind of zoom into it, you see that this is the prostate gland, this is the anal canal, this is the ischioanal fossa, this is the bladder that they're talking about, this is the rectus abdominis. All right, you see this muscle, it's gluteus maximus. Okay, so I think it was pretty clear. Okay, next question. All right, okay. Trauma workup is notable for bruising over the chest and suprapubic tenderness. CT scan of the chest, abdomen, pelvis reveals rib fractures and pelvic fracture, which are the following portions of the urogenital tract is most likely injured through patient. All right, the patient hasn't been able to urinate since so we know that there can be urethral fractures, or what gets involved?
It's because of pelvic fracture. So because of pelvic fracture, most commonly injured part is the posterior urethra injured.
Yeah.
Because pelvic fracture and the trauma associated.
Yeah.
And this
All right.
straddle type of injury can lead to rupture of the anterior urethra. That's the D and E. So the C is the posterior urethra part. That is always injured in the pelvic fractures.
Okay, so it's C.
Yes.
All right. Okay. Yeah. Again, we know that this is a posterior. Okay. In injury of the pelvic bone, you can have posterior urethral injury as well, and that is why there is this thing that you do retrograde cystourethropography. All right, and you kind of check if there is any urethra injury. They can present as blood at the meatus as well, and you have to check for any sort of urethral injury, because in any sort of urethral injury, catheterization is contraindicated. So you will not catheterize the patient until and unless you are sure that the patient is not having urethral injury. All right, and for that you first do retrograde cystourethropography. Yeah, they haven't mentioned it over here, but again, that's just an add-on what I told you guys. Okay, all right. See, I told you blood at the urethral meatus. That's what I told you guys, right? So they can also tell you that they have blood at the urethral meatus as well. Okay, and we go on to the next question. Shows the ovaries and primary composed of connective tissue, which of the following additional abnormalities can be found in the patient? Fatal aortic dissection. What are they referring?
The Turner
Turner
syndrome.
syndrome.
renal
Okay.
fusion.
All right. Again, we talked about how they have horseshoe kidneys. Okay, where do they get stuck at? What's that place called?
At the
Inferior mesenteric
I may.
I am very good. Inferior mesenteric. All right. On ultrasound, the enlargement is found to be a fluid collection around the right testis. The specific embryological defect giving rise to the patient's condition can also lead directly to which of the following. All right, so we have a right scrotal enlargement. Patient has been, that's been present since birth and increases when he cries or strains to pass bowel movement. All right, there is no pain, no discoloration. What's this?
The indirect. It's the
Hydrocele, so
hydrocele.
indirect
Hydrocele is the
hernia.
cause of weakness
In-
of the processus vaginalis, and
Mhm.
That is
that's
a
also
hernia.
the cause of indirect inguinal hernia.
Yeah, so it's a very easy question. We know that, what a hydrocele is. So whenever they say about there's a fluid collection, again, means are referring to any sort of water presentation within the body. Again, they're referring to hydrocele. You can also do a test called a transillumination test where you pass the torch. So the torch light will pass through water or any sort of fluid. But if it would have been a varicocele or a hernia or a mass, the light would not be able to pass through it, right? So that is how you can differentiate between a hydrocele and the other conditions of any sort of enlargement. Again, whenever there is a hydrocele that's developed, it is because of the processus vaginalis defect, and that is why there is this water that kind of comes out and kind of settles over here and forms a hydrocele. Again, all right, okay. So where do you see direct inguinal hernias? Who has direct inguinal hernias?
Old age,
Old
with
age. Very
Old
good.
age,
in the
So
men.
Paris fascia weakness, yeah.
and it is medial to inferior mesenteric, inferior epigastric.
Very good. I don't know if you've read this mnemonic in first aid, MDs don't lie. Have you read that? And if you kind of read that, then you see that MDs don't lie. It usually tells us that medial direct, and then there is lateral to inferior epigastric. All right. Okay. What do you mean by hypospodiasis? What's that?
It's the opening of
You're
the
the-
urethra that is on the
Undersurface.
under aspects, under surface.
the post.
Mhm.
Ventral
Ben-
Yes.
portion. Ventral portion. All right. So if it would have been on the anterior portion, it would have been
Epi.
epispadiasis, right? What do you mean by orchitis? What's orchitis?
Inflammation of the
Just inflammation.
Very good. Inflammation of the testis. What complication? What disease can cause the complication of orchitis?
mumps.
Mumps.
Mumps, yeah.
Very good. Mumps. All right. What's this?
A uterus.
This is a cut section of the uterus. Yeah.
Adenomyosis.
All right, again, so what's happening is that there's this woman who comes because of painful heavy menses for the past 6 to 5 months. Patient has 4 to 5 days of heavy bleeding. All right, HMB. Menstrual periods occur every 28 to 30 days. The patient is on contraception. All right, okay, so what's happening? The hysterectomy is performed, and you can see this. Which of the following is most likely the diagnosis? What's happening?
Adenomyosis.
Adenomyosis, yeah.
Adenomyosis. Why do you think it's adenomyosis?
Because
This is
it's a
significant
heavy
enlargement of
bleeding.
the uterus.
Heavy
Taking
bleeding.
myometrium due to endometrial tissue migration down there. Bleeding.
Mhm. All right. Okay. Yeah. Very good. So let me put in the answer and kind of explain to you. So whenever they say about that, it's adenomyosis, they will give you a uterus that's tender and boggy. That's, the buzzwords of USMLE step 1. Whenever they say that we have a tender, boggy uterus, most likely they're referring to adenomyosis. And other giveaway is that adenomyosis is really common in this age group of women. All right. If it would have been a younger patient, then what? Then what would have it been?
Leiomyosis.
Leiomyoma.
Fibroid.
Leiomyoma.
Leiomyomas.
All right. Okay. So if they, so the age is very important. If it would have been a nulliparous woman, young female, then most likely they would have been referring to a fibroid presentation. But if it's, an older age woman and they also say that the uterus is kind of enlarged under and boggy, most likely they're referring to adenomyosis. Or that's kind of the differentiation, because sometimes on exam, fibroids and adenomyosis can present in a similar presentation. So that is why the age group is really important for you to kind of differentiate between them. Again, we know why it happens. Again, see heavy painful menses, uniformly enlarged globular uterus, and you also see the abnormal presence of endometrial glands and stroma within the myometrium. All right, okay. All right, okay. Okay, I think, all right. Another question, physical examination shows digital clubbing at transrectal ultrasound shows bilateral absence of vas deferens. Where do you see this?
Cystic fibrosis.
Very good. So, how will you diagnose it?
So it
How
will be the chloride level.
Chloride level in the
Chloride.
sweat, yeah.
That's right.
there's other thing you also do is intranasal negative transepithelial test.
Mhm.
I don't know if you guys are familiar with that in cystic fibrosis as well. There's this negative I forgot the name, intranasal negative
Mhm.
transepithelial test, something I've forgotten it, but there's also that test. We also do that in cystic fibrosis patients. So I just want you guys to be aware of that. Knowledge is power. Try to get it from everywhere. All right. See, I just put this line as a highlight and I said, oh, cystic fibrosis chloride level. We did not even need to read the entire question. And that is why I say that USMLE is step one. In fact, all USMLEs are really easy because they make it really easy for us to get the answer out of the question. All right. Primary ciliary dyskinesia, again, those people usually, where do you see primary ciliary dyskinesia? Where?
Cartagena syndrome.
Protagonist syndrome, yeah.
So you have
Very good. So you have like multiple things going on. Like you may have situs inversus, you may have bronchiectasis, you may have digital clubbing or nasal polyps. So all of that's primary ciliary dyskinesia. Cystic fibrosis. I want you guys to remember mutation in the CFTR gene that leads to there's this thing called delta F508. I don't know if you guys are familiar with that, but I'm gonna pull it. You guys are familiar with that?
Yes, 508 delta.
Yeah, so there's this delta 508. It's really important because they ask about that. All right, yeah. So this thing you don't remember, just remember that there's this delta F508 mutation in the CFTR gene. It's very high yield because they do ask that in the exam. All right, okay. So yeah, this was I was talking about. Abnormal nasal transepithelial potential difference, and it usually comes out negative. So that's important. All right. Okay. Let me go on to the next question. In normal female development, non-fusion of the urethral folds from the labia minora and the vestibule of the vagina. In males, non-fusion of the urethral folds would most likely resolve with the following. We talked about that. What's that?
It's
Hypospadia.
Hypospadia.
non-fusion of urethral folds leads to
Hypospadia.
Abnormal urethral opening.
Abnormal?
Urethral opening.
Urethral opening is on the ventral side, yeah.
So what do you think the answer is?
Hypospadia.
Hypospadia.
So we talked about that there's this ventrally placed urethral opening, and that's hypo, and if it's kind of upwards, and that's epispadiasis. Why is it occurring? Again, because of the incomplete fusion of the urethral urogenital folds in the hypospadiasis. If it would have been epi, then what?
Epispadias
on the vent.
The surface.
Because of the genital tubercles abnormal positioning. All right. On examination, heart and lung sounds are normal. He has bilateral gynecomastia. All right. So whenever they say that there is this young boy who comes in with height is 98 percentile, weight is 75, he's having bilateral gynecomastia. The
Klein-
Taylor or
Klinefelter syndrome.
Klinefelter, very good. What's going to happen?
and
So due to meiotic non-disjunction of chromosome X.
X.
Yeah,
Yeah.
very good. Again, very easy. So Klinefelter, they will talk about, bilateral gynecomastia is really high yield. Again, because you're becoming a woman, and that is why you have small firm testes, and that's a sign of infertility as well. Okay. Yeah, we talked about that. All right, I want to come down a little bit. You have this thing called primary hypogonadism, and it's caused by meiotic non-dysfunction. Again, you also see learning disabilities and a lot of behavioral problems as well. What do you see in Fragile X? What do you mean by Fragile X?
Fragile X.
Macro, everything is increased. Long face, long
Long.
macro size of the ovary of the testes, and mhm.
In Fragile X, you put
Intellectual.
the chromosome
Long
Nucleotide repeats.
intellectual.
folate deficient medium, and then the X chromosome, a part of the X chromosome may break off.
Mhm.
Yeah. So in Fragile X syndrome, so they have like large ears, intellectual disability, prominent chin, and then long narrow face. If you kind of memorize this picture, it's really hard for it's really easy for you to understand. There's also this thing called macroarchaism, and they have one testis that's kind of bigger than the other one. And yeah, okay, then we go on to the next question. Tenderness in the lower vertebral area, osteoblastic lesions, man. What's happening? What sort of cancer?
Spread.
C of the
There's a
prostate.
spread.
Prostatic
Could
cancer.
be. It
So
could
blood
be
test.
Prostatic
of
cancer, yeah.
prostatic mets, because the
Yeah.
old man and the osteoblastic lesions both are going in the favor of osteoblastic mets. So
blood
it could
plays
be prostatic
button.
mets.
Yeah.
All right, where did it drain?
They because of
Venous
prostatic
plexus. Prostatic venous
plexus,
plexus.
venous plexus. Could be
Option E.
E.
Where do
Yes.
para-aortic lymph nodes drain?
The testicular
Yeah, testicular and the
testicular
ovarian.
and ovarian
Ovarian.
lymph nodes
Testicular,
drain to
parotic,
the
then scrotum is suprainguinal.
All
It's the
right,
E.
No. E.
It's the E. Yes.
E is the answer, prostatic venous plexus.
all right, okay, yeah. So again, we know that they're talking about prostate cancer because you see osteoblastic lesion. Again, you see a very old man, difficulty having urination, which means we're talking something that's wrong with the prostate. And the most primary location for metastasis for prostate cancer is the spine. That is why you see osteoblastic lesions in the lumbar vertebra, and consequently, you have back pain as well. Again, where does it drain? It drains in the prostatic venous plexus, as the name indicates. It's it's kind of very self-explanatory. Again, the other high yield thing from over here, these two plexuses are really important. Campaniform. Where do you see campaniform plexus plugged? In the varicose
Around
vein.
the testes. Around the testes.
Yeah, so I said that whenever the campaniform plexus is plugged and it's obstructed, there's this condition called varicocele, and that happens. Parotid lymph nodes you will find within the ovaries, testes, very important. Vertebral artery, they don't ask this. These three are they're very high yield for you to remember. All right. Next question. Okay, what's happening? She has a low hairline, a short wide neck, just widely spaced nipples. What are they talking about? Very easy.
Turner syndrome.
In the
and
Turner
Turner. Non-disjunction.
Meiotic non-disjunction, yeah.
Yeah, so again, we talked about this, so I need to go over this again. All right, the right hemiscrotum is swollen and tender. This is the specimen that's kind of shown to us. Severe right groin pain. There's this boy, and he's sexually active. All right, sexually active. Okay. Then
This testicular torsion.
Testicular torsion. Yeah.
yeah.
because of an anatomic defect causing
Anatomic
increased
defect.
mobility of
Mobility
testes.
of the
That's B.
testes, yeah, B.
Yeah, B.
Yeah. Again, so whenever they're talking about anything torsion related, that means they're saying that, there was a lot of pain, severe pain. These
Mhm.
words are, kind of very distinct for torsion. And you will see, the twisting of the spermatic cord, and, you will see the same findings, nausea, vomiting, as what you saw in ovarian torsion. Again, examination findings will have a solid hemispodium absent from gastric reflex. Where do you see a positive from gastric reflex?
Sorry, what did you say?
Where do you see a positive gastric reflex?
Normal.
Normal. This is a normal procedure.
Normal.
Yeah.
Normal
Very
response.
Very good. Okay, again, so you have to immediately take the patient to surgery to kind of detours. Otherwise, it's going to be problematic. All right. Okay. What is the most common cause of orchitis in young adults?
Neisseria infection.
Moms too. I don't know.
I said young adults. What about epididymitis?
Infection. Mhm.
What infection?
Neisseria.
Neisseria.
Bacterial migration from the urinary tract.
So it can be, any STI. It can be gonorrhea. It can be,
Yeah.
E. coli is usually in older patients, and gonorrhea is usually in younger adults who are sexually active. And in older patients, it's most likely E. coli. All right. Okay.
Mhm.
Then we go on to the next question. Okay. There's also a 6 centimeter irregular immobile firm mass in the right upper quadrant of the breast. The left breast appears normal. The patient's skin findings are likely to malignant infiltration of what? So, there's a skin puckering on the right breast of a 61-year-old woman that's, there. And she does not use anything. Her last menstrual period was 8 years ago. What's happening? So there is no discoloration, but there is a prominent non-tender skin retraction.
Breast carcinoma. Yeah.
Can lead to puckering of suspensory ligaments.
Yes,
Suspensory
suspensory
ligament.
ligament is the answer.
Suspensory
Cooper.
ligaments can
Mm.
cause the skin puckering.
Yeah, again. So how do we suggest that it can be breast cancer? First, that they said that there's this irregular. Whenever they say that there's irregular, aggressive, bad words associated with anything, most likely they're referring to that. So yeah, they're most likely referring to cancer. Okay, right. So these Cooper ligaments, you see that, and yeah, so it's easy. Where do you see purity orange?
Orange peel consistency.
It's when the
Mm.
carcinoma spread through the lymphatics, it gives the appearance of pudgy orange appearance.
And what disease do you see that? Purity?
Malignancy, because of malignancy.
And Paget's disease too, I think.
Paget's
In
too.
Paget's disease of breast.
well,
Yeah.
you also see Paget's disease. You also see purity orange as well. Okay, then we go on to the next question. Okay, orchiopexy, the placement and fixation of the testis is the scrotum is recommended to the family. During the patient's procedure, the malpositioned testis will most likely be pulled through a physiological opening in which of the following. What's happening? Why is the patient having orchiopexy?
Trapping of the testes at the inguinal canal. So it's an incomplete descent of the testes from the abdomen. It's the abdomen, the testis or the testicular material got retained at the inguinal canal by what the question is saying. So that's the cause of the orchiopexy in this case.
All right.
So in this case, you need to go through the external oblique aponeurosis. That's the option B to be able to relieve symptoms.
All right. So what's the answer?
Okay. It's a fixation.
A.
External
Fixation.
oblique,
A surgery
external
to
oblique
fix the testis.
aponeurosis. Answer B, option B.
All right. Okay. Yeah. Okay, then this is the last question for today. Prior to administering local anesthesia, the physician palpates for distinct bony protrusions located in the posterolateral vaginal side walls. A firm band can be felt running medially posterior from each of the bilateral bony protrusions. The anesthetic agent is injected around the bony prominence. Which of the following nerves is most likely blocked by the injection?
Pudendal.
Dental. Very easy. So yeah. In vaginal deliveries, again, pudendal nerve is at risk for injury. Again, so when you're kind of administering a pudendal nerve block, you have to go through this pathway. The physician will palpate the ischial spine, and then they will block it. Again, we are done for today. If you guys have any questions, you can ask me, and there will be Dr. Ahmed continuing, I guess. Yeah. Oh, I see an increased participation today. 60 students present. Very good, guys. Keep it up. I see great participation within the chat as well. Good job, guys. Do you have anything to ask before we end the session? No?
This second last question, Dr. Maheen, could you please explain just for a minute? I didn't get that point. The second last question, which we did right now.
I exited it. Wait, let me go on.
Was the 21, I think so.
Yeah, let me go and let me just log in back to Uworld and
I didn't get what they were asking about.
then I forgot what they were asking about.
Oh.
So it's okay.
It's okay. It's okay.
Yeah, okay. Second last question. What was this? When did we do this? Oh, did we do this? Wait, okay. So you guys can see my screen back again. All right. So we know that the testicles are develop in the fetal abdomen and they have to descend downwards. All right. If they do not descend and they stay in the abdomen, then there's this condition called cryptotorchidism that occurs. And so when a male newborn is born, you have to look for testes. If there is this condition called cryptotorchidism, which means that one of the testes or even both of the testes have not descended from the abdomen to below, then that means that this condition has developed. You advise the parents to wait for 6 months, all right, because naturally they will descend. If they have not descended as of now, you wait for 6 months for their descent. If they still then don't descend, there's this condition called orchiopexy, which you do. If you do not do this, then the patient will be at risk for infertility or cancer. We have to worry about cancer more, testis cancer. And why am I saying that? Because the abdomen is not the natural place for the testes to be. It should be down below where they can be kept at a cooler temperature. In the abdomen, the testes aren't that in a cooler environment as they're down below, and that is why they're more prone to developing cancer in these conditions. All right. So you have to worry about two things: infertility and cancer. Okay, so there is this opening that you can kind of go through, and that is this case. All right, so it's in this case, the patient's undescended testicle is within the inguinal canal, and it must be mobilized through the superficial inguinal ring. All right, we know that there are two inguinal rings, direct inguinal ring and superficial inguinal ring. So we can, kind of restructure the testis back from the abdomen to the original position via the superficial inguinal ring, and that is present within this muscle called external oblique aponeurosis, and can then switch it to the scrotum. All right.
Yes, thank you.
Okay, got it. All right, no more questions. And Dr. Ahmed is here. Dr. Ahmed, are you here? Be here. Hello. Dr. Hamza, are you here? Who is here?
So I think I will take on the
Oh,
classroom.
hi, Moaz. Okay,
Hello,
yeah,
how are
sure.
you?
Okay, yeah, you sure you can continue. All right. Okay. I'll be seeing you guys tomorrow. If you have any other questions, you guys can leave a text on WhatsApp. Dr. Moaz will be continuing the class, and I will see you guys tomorrow. Okay.